This is Dr. Harshman of Dr. Harshman's Medical Cost Control. Welcome back. I want to apologize for the buzzing during parts of the first two shows. I had to get a hearing aid. It doesn't work very well. It seems to flicker in and out. Works all right now, though. Dr. Harshman's Medical Cost Control.
It's General Muddles.
Oh, hello, General Muddles. General Muddles is a distinguished war veteran and the fund manager for Confabulator's Global Square Root of -1. It's an imaginary union, so it has an imaginary number. What can I do for you?
What the hell is going on with your show?
What do you mean?
Loud buzzing. Do you know how many claims for hearing aids we've had to pay? There must be a claim from everyone who's seen it.
I'm very sorry. How many claims have you got?
2. One from you and one from me. And you call yourself a cost control expert. Such expense you've put us to.
I think we'll do better from now on. I finally traced the problem to a loose wire in the microphone plug. I hope that works, and I don't think we'll have any further problems with the sound.
What's that? I can't hear you.
I said I don't think we'll have any further problems with the sound.
I can't hear you. I think we're having problems with the sound.
What did you say? I think my hearing aid isn't working.
Speak up, will you? My brand new hearing aid is busted.
I said I can't hear you, and I think your hearing aid is broken.
I can't understand a word you're saying, and your hearing aid isn't worth a damn.
What? This hearing aid is not helping. Can you hear me? Now, where was I? Oh yes, I promised to discuss the gatekeeping strategy of HMOs. We began with the definition. An HMO is an organization that gets paid per patient per year and pays for the healthcare services that it provides. Obviously, it wants to minimize its healthcare service expense. It cannot, in general, allow unlimited healthcare service expenses on demand. Conversely, access to expensive resources is sometimes necessary. A gatekeeper is a person or protocol that attempts to control healthcare costs by restricting patients' access to expensive professionals or technology. But how do you prevent unnecessary access to resources without inadvertently excluding patients who really need them? In a fee-for-service structure, the answer is easy. Just raise the price to a profitable level and supply all the demand. In the healthcare context, price can act like a gatekeeper. So does the time and trouble of seeing a doctor. In an HMO, time and trouble can be gatekeepers, but the doctor's charge cannot. But apart from inducing long and unpleasant waits, what can an HMO do? In a competitive environment, it cannot create unpleasant relationships without driving its patients away. Any actions that are recognized by patients as discouraging the use of healthcare services will result in loss of business to competitors. Conventional logic will not solve the problem. I ask you, how can an HMO restrict access? You think about this for a while. There is an answer. Dr. Harshman's Medical Cost Control.
Hello, Dr. Harshman. This is Biller Killer Mishmash.
Biller Killer Mishmash. He is a fictitious, eccentric, and hard-headed physician negotiator. But if there's a way to cut payments to providers without cutting quality, he'll find it. Believe me. Hello, Biller Killer Mishmash. What can I do for you?
I think I've got an answer to your question. You say conventional logic will not solve the problem? What about unconventional logic?
Unconventional logic. That's right. But how?
You remember that statement about actions being recognized by patients as discouraging the use of healthcare services?
That's exactly right.
Well, suppose they don't recognize them.
Perfect. A way must be found to discourage patients from unnecessary use that they won't recognize as such. Thanks, Biller Killer Mishmash. I'm happy to learn that someone's watching. Suppose a patient approaches an HMO and states a need for medical care. The patient may have genuine physiologic need, or the patient may have a genuine but minor problem that can be handled without professional intervention, such as a bad cold. Or the patient may have an organically caused ailment with its principal symptom one that is usually psychologically induced. The last condition is easily barred from treatment by carelessly written gatekeeper guidelines and can cause serious distress, illness, or death. It must be avoided. The first condition, the genuine need, should receive attention and can be fairly easily identified as needing it. The second condition, the minor problem even with dramatic symptoms, can be excluded if it can be identified. But how? No HMO executive can write fair gatekeeping guidelines that take information from a patient and use it, and only it, to permit or deny healthcare service. Suppose an HMO set up such guidelines. Some patients would, by trial and error or an insider leak, learn the guidelines and would lie to get healthcare if they believed it necessary to do so. Then the guidelines would need to be changed, the waiting times increased, the co-payments raised, the staff made irritable, or something else would happen that is not to the patient's advantage. Therefore, guidelines that exclude patients when they believe that they need health care cannot survive in the long run. Do you think patients will always be truthful when requesting health care assistance? Consider what happens when a physician receives complaints of nausea, vomiting, and fever and suspects the flu. The physician takes a history, examines the patient, and prescribes rest, fluids, and so on. It is, of course, important to make sure that the patient does not have appendicitis, gallbladder trouble, a kidney stone, pancreatitis, or another serious condition. But these conditions can be excluded with reasonable certainty by a careful history. Although laboratory tests and special x-rays are of theoretical use in excluding kidney stones, for example, a simple physical examination is not helpful. A physician can and should explain what the danger signs are in case the diagnosis of the flu proves to be wrong. But these danger signs are in medical books for the trade and for the public. A patient with access to such books has no reason to call a physician for uncomplicated flu-like symptoms. Suppose an HMO has a medical professional screen requests for medical evaluations and says that certain abdominal symptoms do not deserve a personal medical evaluation. Then patients with them are likely to feel justified in trying to beat the system. Some non-HMO patients visit physicians when they have such symptoms, even if they have to pay the physician themselves. They feel sufficiently strongly about needing a physician to pay the dollar price. They are not likely to accept fiats passively. We must expect them to lie. So what guidelines work? HMO personnel cannot explicitly turn away a patient who does not need health care. The patient may really need it. They must continue to make it available, but make the patient decide to turn away. A patient with the flu who, when confronted with the medical facts, still insists on personal medical evaluations must be doing so for irrational reasons. Any rational patient would accept that the flu is unpleasant, may moan and groan with discomfort, and would get the treatment without running or crawling to a physician. If the facts are known to a patient of sound mind, then consulting a physician will do the patient no rational good. The motivation for the visit must be irrational. This motivation must be identified and used to advantage by the HMO gatekeeper. But you can't just ask a patient, "Are you coming here for an irrational reason?" Remember that patients must be assumed to be willing to lie to get past a gatekeeper. So exactly what does a physician supply? Healthcare knowledge and advice and personal attention. What an HMO must do is to provide the healthcare knowledge and skill, but not encourage patients who need only personal attention. The key here is the conventional assumption that verbal interchange between the patient and the HMO member must take the form of natural conversation. That assumption is false. A patient's willingness to encounter an unnatural, though respectful, interaction pattern indicates that the patient is not primarily interested in personal attention that takes the form of natural conversation. The unnatural pattern is, therefore, an addition to a gatekeeper mechanism. The psychoanalyst-patient pattern of interaction is an example of an unnatural means of communication between clinician and patient. Another example is the use of a questionnaire or a device such as a computer terminal, rather than a person, as a means to begin taking the patient's history. The latter examples have the drawbacks of being potentially difficult to use and being serious problems for patients who cannot easily read, but they have the advantage of excluding patients who primarily seek human interaction and who approach the healthcare system for that reason. In sum, restricting natural human interaction as part of the gatekeeping mechanism appears useful. I recommend the use of 2 questions by HMO gatekeepers. 1. What do you expect the doctor to do? And, if the answer does not involve the straightforward use of medical skill not in layperson's books, or lab tests, or prescription drugs, or other such physician-only treatments, question 2. In what way do you expect that to be better than what you could do for yourself? These questions help discourage attention seekers while not excluding the patient with an organic illness that has hard-to-trace symptoms or that mimics psychogenic disease. Patients deserve treatment, of course, but they should be worse off materially or otherwise on their terms when sick than when well. The patient's terms for believing themselves worse off will include time prices, social rewards for being healthy or sick, and other criteria that are hard to quantify, in addition to out-of-pocket expense and lost earnings. Most patients will feel worse off when sick than when well, but not all will. As evidence, note that a standard procedure for detecting psychogenic paralysis in the arm is to have the patient lie flat and let the arm fall so that it will hit the patient's face if the arm is paralyzed. If the paralysis is not organic, then the patient's arm will miss the face. Genuine seizures can be distinguished from imitation seizures by rubbing the breastbone so as to cause pain. A patient having a genuine seizure will not resist. Note also the use of the same side hand to help drag a non-organically paralyzed leg, a mannerism that I believe has no locomotor significance, but that focuses attention of the patient and others to the disability. People watch hands and pay attention to what they are doing when there is bodily motion. The important inference here is that psychosomatic disability appears best distinguished from organic disability by physicians by placing patients in situations in which the genuine disability would make the patient worse off than its absence, and in which the patient with psychogenic disability does not expect the brief and purposeful absence to be noticed. The helping hand walk fits this pattern because it is an attention-getting mannerism. Dr. Harshman's Medical Cost Control.
This is Ivan U. Block. Remember me? I got that bypass graft from Dr. Emma T. Poquette. She wanted $6,000 and Biller Killer Mishmash knocked the price down to $3,750.
Oh yes, I remember that. You had some difficulty raising the $500 she wanted up front. How did that work out?
I called General Muddles, as Biller Killer Mishmash suggested, and he set up the credit union. Meanwhile, my boss guaranteed a loan for me.
Great. How are you feeling?
My heart is doing great, but my arm and my leg keep going limp. Any idea how to find a good neurologist?
I don't know of one offhand, but you might try the Mensch Medical Group. They provide excellent internal medicine for surprisingly decent prices, and they'll give you a referral if they don't have a neurologist right on their staff.
Thanks. Do you know their phone number?
You got a touch-tone phone?
Yeah, there's one in the other room. Hold on, I'll pick it up there. Go ahead.
You dial 5555, and when you hear the voicemail menu, you press the Mensch button on your phone.
Mensch button? I never heard of it. Let me look. Well, well, what do you know? Here it is. I never noticed it before.
I'd like you to show our viewers what happens when a person is really paralyzed. Can you come over?
Sure.
Oh, great. I wonder if Biller Killer Mishmash would be interested in pretending to have a limp arm or leg. He does excellent work with physician negotiated. But maybe he'd be a good actor. Let's try it.
Haggle Docs.
That's his business name. Hello, Biller Killer Mishmash.
Yeah?
It's Dr. Harshman.
Hi, Doc, how are you?
Oh, doing great. Listen, I got a small part in my show for an actor. You would play the part of someone pretending to have a paralyzed arm, and in another scene, a paralyzed leg. You want it?
Okay. Give me a few minutes, though. I got this lunatic of an antitrust attorney on the phone. I got less than 5% of the market, and he says I'm price fixing. Do you know if the organ transplant program takes live donors?
I doubt it. Good luck. Oh, hello, Mr. Block. Lie right here in front of the camera, and I'll show our viewers what happens when an arm is paralyzed. Ow! Watch what you're doing, will you? Thank you, Mr. Block. Next, we'll show what happens when a patient has psychogenic arm paralysis. Thank you, Biller Killer. Let's watch Mr. Block walk with a genuinely paralyzed leg. As you can see, Mr. Block's walk requires a great deal of energy, but Mr. Block himself still manages to keep his hands free. People with real leg trouble often have a tendency to fall. Dr. Harshman's medical cost control.
This is Ivan U. Block. Can you recommend a good orthopedist?
No, I'm afraid I can't. Sorry. When they fall, they often hurt themselves. Now we'll watch a patient with psychogenic leg paralysis walk. Thank you, Biller Killer Mishmash. As we have seen, a truly paralyzed arm will hit the face and a psychogenically paralyzed arm will not. This is evidence that psychogenically induced representation of illness stops when it is in the patient's best interest for it to do so. Similarly, patients with genuine leg weakness are much more likely to fall and hurt themselves than patients with psychogenic leg trouble and the same reported symptoms. By appropriately structuring the process by which HMO patients request health care, one can take advantage of this difference and have patients select for themselves if they want a particular physician visit or not. Most calls for services from providers by patients are unrelated to psychogenic conditions. Nevertheless, there may be a reason unknown to clinicians why a patient would be better off sick than well. Additionally, even with organic illness, there may be a component of preferring the sick person role that makes the true motivation for a patient seeking health care difficult or impossible to identify, as with the flu diagnostic process above. An HMO should treat patients so that they are better off well than sick. If patients are free to switch their medical care needs from one HMO to another, in a competitive market as opposed to a national health insurance market, then the use of restricted personal attention and assignment of responsibility as gatekeeping mechanisms have another advantage: deselecting. Patients who primarily seek attention or have other undisclosed psychological reasons for seeking health care, even if their attitudes and preferences cannot be altered, would be encouraged to seek treatment elsewhere. Meanwhile, patients who have organic health care needs and who follow instructions about arranging for their treatment willingly will receive perfectly good medical treatment. The HMO staff need not be concerned with which patients are attention-seeking, dependent, or similarly motivated. The latter will become dissatisfied and will leave on their own if allowed to do so. Join us next week, same time, same channel, for another episode of Dr. Harshman's Medical Cost Control. My time has come, and I must fade away. Public Access Program Guide of all the shows on Public Access. Send a self-addressed stamped envelope, 2 stamps, a 29 and a 23, that's 52 cents postage, to Access Manhattan Magazine, Department EJH, Box 319, Gracie Station, New York, New York, 10028. Please specify if you want Paragons or Manhattan Cable's schedule. It's free.